Welcome everyone to today's presentation. Just a bit of background, the Pro Patria Centre has been established to provide resources and support to our wider community. And today we're excited to present Neuroinflammation, the road to neuropsychiatric conditions with Dr. Mark Gordon. We'll have time for questions at the end, so please use the platform to submit your queries and Jackie will field them into the page. To begin, I'd like to formally introduce you all to Dr. Mark Gordon, MD. Dr. Gordon is a leading neuroendocrinologist and pioneer in treating traumatic brain injuries through innovative hormone-based and anti-inflammatory protocols. Since 2004, he's advanced the field of neuroendocrinology, emphasizing the critical role hormones play in brain recovery and mental wellness. Today, he brings deep insight on how inflammation disrupts neurochemical pathways, linking TBI to psychiatric symptoms like depression, anxiety, and cognitive decline. Dr. Gordon has featured multiple times on the Joe Rogan Experience, discussing brain health, hormone optimization, PTSD, and neuroceutical interventions through the Millennium Health Store. Following the Royal Commission's focus on veterans' mental health, and in light of Australia's first formally diagnosed veteran TBI case, Dr. Gordon's work brings new light to pioneering Australia's first protocols, showing real-world outcomes and signalling a shift in our national approach to brain injury diagnosis and care. We're honoured to have Dr. Gordon here with us to share his groundbreaking work, melding science, patient stories, and clinical rigour to reshape understanding and treatment of TBIs and neuroinflammation. Please welcome Dr. Gordon.
Thank you very much. I'd like to thank my new colleagues at the Pro Patria Center, Jackie and Jason, and my friend Jeffrey, who has spent the last year studying the materials I'm about to share with you tonight, or today. It's nighttime for me. Let's see, why is something coming up there? Okay. And I'd like to welcome those of you that are meeting for the first time, and I look forward to establishing a similar relationship by sharing this information. The presentation before you focuses on the often overlooked effects of subconcussive and mild concussive brain trauma on cognitive and emotional well-being. While the literature clearly recognizes these as legitimate forms of traumatic brain injury, subconcussive trauma remains frequently undetected due to its lack of immediate observable symptoms, unlike mild TBI, which typically presents with clinical signs and symptoms. This presentation explores how trauma, defined as the primary injury, initiates something called the secondary injury through neuroinflammation, disrupting the brain's chemistry, hormonal balance, immunity of the brain, and the neurochemistry. We'll examine the role of oxidative stress, which is free radicals, and immune activation in creating a toxic neural environment where critical elements will be destroyed, leading to neuropsychiatric dysfunction. Our focus is on strategies for prevention, protection, and recovery. Historically, medications have masked symptoms rather than address the root biochemical dysfunction. Since 1995, the Millennium's mission has been to identify and correct these causes, restoring individuals to their pre-injury state. As we journey through this neuroendocrine, neuroimmunology, and neurochemistry, we'll focus on how subconcussive and concussive trauma triggers inflammatory pathways that drive long-term neuropsychiatric outcomes. Neuropsychiatric outcome just implies that the brain creates these psychiatric conditions as opposed to just calling them psychiatric conditions. Whether or not you come from a neuroscience background, I'll do my very best to explain things so that everybody from all levels will understand what I'm talking about. So let's begin. Subconcussive brain trauma, especially in contact sports and military settings, involves repeated low-force head impacts that don't cause immediate symptoms, but can still disrupt brain function. Sometimes the symptoms from the subconcussive or microtrauma can be headaches, fatigue, dizziness, vertigo, trouble concentrating, mood shifts, sleep disturbance, and sensitivity to light and or sound. Because these events are not overly disabling, they often go unnoticed, thereby allowing the individual to return to the activity that precipitated the condition. Over time, these microtraumas trigger the cumulative changes in neurochemistry, neuroendocrine, and induce neuroinflammatory development, leading to long-term cognitive and emotional impairment. This absence of clear clinical signs from the subconcussive underscores the need to move beyond traditional concussion-focused models and address repetitive microtrauma, precisely the mission the Millennium has pursued since 2004. The clinical focus on mild TBI, especially those involving loss of consciousness, has unintentionally sidelined the recognition of subconcussive brain trauma. Since individuals who don't meet the standard TBI criteria, mild TBI, moderate TBI, are often labeled with PTSD, post-traumatic stress disorder, or a new onset psychiatric disorder. Considering shaken baby syndrome, this is in infants who suffer being shaken, and 30% mortality rate just from being shaken very intensely. And the survivors of this have long-lasting developmental challenges. This isn't due to overt injury, but to something called mechanotransduction, where the collision of cells sets off a cascade of signals to generate inflammation in the brain, which comes from our immune system. These chemicals are called cytokines, which drive both tissue loss and disruption of the brain's delicate neurochemical balance. Brain trauma unfolds through a cascade of neurometabolic changes. Its effects evolve over days, months, or even years. The initial trauma is typically classified as mild in 80%, moderate in about 15% of the cases, and 5% are severe. But what about the millions of civilians and military alike who experience trauma so subtle it doesn't register clinically and hasn't been even given a name, a proper name? In the acute phase, trauma can bruise the brain, which is called a contusion, which can cause bleeding and raise the pressure inside the brain, which causes pressure on the blood vessels, which can lead to poor blood flow, can lead to lower oxygen, hypoxia, and low blood sugar, hypoglycemia. As pressure builds, the lymphatic system becomes impaired, slowing its ability to clear out metabolic waste. This amplifies something called free radicals, which produce oxidative stress, activate immune cells to produce more inflammatory cytokines, and is the hallmark of secondary injury phase. CT scans and MRIs can detect skull fractures, hematomas, blood accumulation, ventricular compression, the air fluid spaces in the brain, and cerebral edema, but they cannot reveal neuroinflammation triggered by subconcussive and concussive trauma. So when you get a CT or MRI done, what are they really looking for? Structural damage, but very uncommon to have it happen. In fact, in the neuroradiological literature, in people who have had loss of consciousness, knockdown loss of consciousness, only 15% of them have physical findings or findings on CT and MRI. 85% of them are missed. As the secondary phase advances, mitochondria dysfunction worsens, increasing the production of free radicals. Now, mitochondria are responsible for energy, and that energy as ATP is what helps to fix the chemistry, to repair cellular functions. And this leads to a deficiency in the ATP leads to the membranes of cells which break down and allow for cells to die. Rising oxidative stress activates more microglia, which are the immune cells, and they set off a dangerous cycle producing more and more inflammatory cytokines, chemistry. Reactive oxygen species are free radicals that have direct effect on the cell membrane that destroy the fats that make up the membrane and allow for triggering of another system, which they call the toll-like receptor 4, which activates an increase of inflammatory cytokines by sending a signal into the nuclear material and say, make more inflammation. At this point, neuroinflammation becomes the dominant force. Adding to the injury, psychological and physical stress elevates the stress hormone called cortisol, which suppresses another chemical called fractalkine. Fractalkine is a key hormone produced by neurons that keeps the environment of the brain calm, not inflamed, not overreactive. But without the fractalkine, because cortisol goes up, the microglia, the immune cells, are producing a lot of inflammatory cytokines because they become hyperactive. As the brain's immune system enters a hyperdrive, chronic neuroinflammation sets in, disrupting the frontal lobes of the brain, which impairs judgment and executive functions. Executive functions, we decide what's right and wrong. We also are able to do sequential procedures like making a cup of tea. You don't pour the water on the floor, you pour it into a cup. You don't put the bag in the garbage, you put it into the water. These are sequential procedures. Also, the limbic system is effective, which destabilizes mood, memory, and emotional regulation. Inflammation of the area called the hypothalamus triggers high blood pressure, insulin-resistant diabetes, neuroendocrine disruption, where you lose the hormones of the brain and body. And it increases something called fight and flight because of the autonomic nervous system. We've had a number of our veterans, I only take care of military, who have come to us with 3, 4 different medications for blood pressure. Within 6, 8 months, they're down to 1. Why? We've corrected the inflammation in the brain, corrected the hormonal dysfunction that occurs. So this is when neuropsychiatric symptoms, often depression and mood disorders, emerge, sometimes for the first time in the person's life. At this point, these microglia, which they call in a group glial cells, remained locked in an inflammatory state. Early repair mechanisms have failed, and the risk of scarring of the brain, called gliosis and astrogliosis, increases, impairing the ability of the brain to heal itself, to reestablish connections that we call synaptogenesis. So your thoughts become foggy. Now that we've set the stage, let's dive into the real core issues of this presentation. Acute neuroinflammation protects the brain, while chronic neuroinflammation destroys it. In acute injury, inflammation is short-lived, resolving in days or weeks. Symptoms may be mild, like those from a cold. You get sick, you don't feel good, you're irritable, you don't want to eat, you can't stand light, people talking, you tell them to get out of the room, and then in a couple of days, it's gone. That's the acute phase. But with repeated subconcussive trauma, this inflammation becomes chronic, impairing brain function over time and driving a steady progression of cognitive and emotional decline. Even in normal aging, a lifetime of subconcussive trauma contributes to gradual loss of brain in what we call atrophy, represented by this upper line. But after a single traumatic brain injury, the rate of atrophy, the loss of tissue that makes up the brain, is accelerated, and you can lose a significant amount of brain functioning in this 3.8 years. Microglia, those immune cells, are the brain's resident immune cells responsible for detecting pathogens like bacteria, virus, and molds, and also to clear out any of the cellular debris that accumulates day to day in the natural function of the brain. In their resting state, they are called M0 microglia. They're in the sedentary position, and that's because of this stuff called fractalkine. It keeps them calm. When challenged, this M0 microglia are activated by free radicals, other inflammation coming from other parts of the body, and create this incredible inflammatory environment in the brain. So when challenged, the M0 go to M1 phenotype, releasing these pro-inflammatory cytokines to neutralize the threats. Once the threat is eliminated or cleared, the M1 becomes M2, which is an anti-inflammatory state, and it's responsible for shutting off the inflammation, helping with tissue repair, and it relies very heavily on mitochondrial production of the energy molecule called ATP. Very important for healing. But under chronic conditions triggered by repeated subconcussive trauma, as well as autoimmune disorders, chronic infections, or even gut inflammation from things like ulcers or dysbiosis, this cycle stalls. Once the microglia are primed, they become hyper-reactive to future insults. In this prime state, even a small insult, like a slip and fall or a fender bender, a very mild one, can produce an exaggerated inflammatory response. It's less becomes more damaging. Both subconcussive and concussive brain injuries activate these microglia and disrupt mitochondrial energy production through the same inflammatory cascade. The challenge with subconcussive brain trauma lies in its silent onset. Symptoms are often delayed, which hinders early detection and timely intervention. To counter this, we must focus on building what we call biological resiliency by optimizing the body's innate protective mechanisms. We'll explore this strategy in detail a little bit later in the presentation. This is a DTI MRI, diffusion tension imaging MRI, which shows what happens when the axons, the neuronal axons, are damaged. They rupture. And what these are cables that are responsible for relaying information between the different lobes of the brain. When these axons are disrupted, they leak intracellular, inside cellular content, which activates the microglia and triggers the pro-inflammatory cascade. This leads to what we call a non-permissive environment, one that is not supportive of health, where information transfers are impaired, resulting in symptoms like mental fog, short-term memory, and cognitive slowing. One of the most frequent and troubling outcomes of subconcussive and concussive trauma is the onset of new depression. In the general population, depression affects 8 to 10% of the people. Within 1 year post-TBI, this raises to 25 to 50%. And by 7 years post-TBI, it's up to 60% of the people experience depressive symptoms. This progression points to the biological cause, not just the psychological cause. You can't wish yourself into depression, generally speaking, but there has to be some change in the chemistry of the brain caused by the inflammation. And ongoing neuroinflammation disrupts enzyme systems, neurotransmitters being produced or synthesized, connection between neurons called synapses, and also the ability of the neurotransmitters to be recognized at what we call receptors. The primary driver of this damaging system is oxidative stress, fueled by rising free radicals released during cellular injury. Astrocytes, are also known as astroglia, are critical for brain balance. Under normal conditions, they clear excessive neurotransmitters, they remove
excessive garbage from the brain. They deliver sugar to feed the neurons of the brain. The brain runs on pure sugar. They support what's called the blood-brain barrier, which is blood vessels that can allow very specific things into the brain, but they block white blood cells from the periphery getting into the brain and a lot of the toxins that we take into our body. And they also produce something called neurosteroids, which are key for brain repair and hormonal balance. And we'll talk about that in a little bit as well. When inflammation strikes and the oxidative stress is elevated, the astrocytes lose all these regulatory roles that they have, and instead they contribute to building a toxic neuronal or nerve environment, which is impaired neurotransmitter clearance, increased oxidative stress, increased cytokines, disruption of the blood-brain barrier, so things leak from the periphery into the brain, which shouldn't be. That's how multiple sclerosis occurs. That's how a lot of conditions occur, ALS and so forth. The glymphatic system becomes dysfunctional. We'll talk about that in a minute. And then the pressure in the brain rises. So this shift fuels chronic neuroinflammation and neuronal dysfunction and death of cells. The glymphatic system was just confirmed being discovered in humans in 2017 and found to be regulated by these astrocytes. Its primary function is to remove metabolic waste and excessive fluid from the brain. Think of the brain's nighttime cleaning crew. That's what it is. However, under inflammatory stress, the glymphatic system fails. And what happens is cerebral spinal fluid accumulates in the brain. The brain swells and the pressure increases. Toxic waste builds up. Nutrient transport into the neurons declines. And this generates a vicious cycle which deepens neuronal dysfunction and accelerates the loss of the brain. Neurodegeneration is Alzheimer's, Parkinson's, and multiple sclerosis, CTE, PSP, which is progressive subcortical palsy, horrible disease, and ALS. So approximately 98% of TBIs in the military and nearly 100% in contact sports are called closed head injuries. The calvarium, the brain, the skull is not cracked. But these still generate a surge of free radicals that are highly reactive molecules that damage neurons. The brain has two defensive systems to deal with these oxidative stress, this enlargement, increase in oxidative stress. One called the glutathione system, and the other one called the superoxide dismutase or SOD system. These are endogenous within our body, antioxidant systems that are the first line of neuroprotection when you have a trauma. However, under chronic neuroinflammation, these systems become overwhelmed, leading to neuronal death and loss of function. But we can support recovery of these systems by enhanced antioxidant regeneration by taking supplements, employing therapies like HBOT, hyperbaric oxygen therapy, targeted nutritional supplementation. Some of them are omega-3 fatty acids, fish oil, quercetin, PQQ, N-acetylcysteine, vitamin C, curcumin, and a whole bunch of other food-derived antioxidants that have documented evidence-based effectiveness. One of the primary free radical families generated by the body in healthy living, it's generated with normal life, but more so in trauma. And those are the reactive oxygen species, which is a natural byproduct of metabolism. At physiological levels, this thing called ROS is beneficial to the brain. It enhances the ability of nerves to communicate, something we call plasticity, neuroplasticity. It strengthens neural communication through this synapses. And it also supports cognitive performance in an area of the brain called the hippocampus. However, when this reactive oxygen species level exceeds the normal threshold, they become toxic to the brain, to the neurons, damaging neurons, and disrupting the communication. That's why you get things like cognitive impairment. Even when you get a cold, your memory isn't as good because the inflammation precipitated by the immune system fighting off the virus creates this disruption akin to all forms of inflammation. In a healthy brain, neurotransmitters transmit signals across synaptic clefts, that's between one neuron to the next, linking the pre- and postsynaptic neurons, much like couplers on train compartments. This precise relay system underlies thought, emotion, language, and physical motion. When neurotransmission is disrupted, particularly in pathways involving serotonin, dopamine, GABA, and acetylcholine, we see impairment in sleep, memory, cognition, and mood. Serotonin, dopamine, GABA, acetylcholine affect sleep, memory, cognition, and mood. Neuroinflammation and oxidative stress can compromise this entire pathway. While oxidative stress harms all cell types, it is especially destructive to the brain's neurons and glial cells. It plays a central role in the progression of neurodegenerative conditions such as Alzheimer's disease, Parkinson's, multiple sclerosis, CTE, and ALS. In stroke, the loss of blood flow deprives tissues of oxygen and nutrients, which causes a sudden increase in inflammatory chemistry, which leads to denigration, destruction of the communication between nerves. That's why you lose motion in certain areas. You lose memory in other areas. A recent article reviewed a broad range of medications targeting trauma-induced neuroinflammation. And what they found was most medications offered limited relief. No single drug resolved the full spectrum of inflammation-related symptoms. But they did find that precision-based approach, which is using stem cells, showed the most promise even decades after post-trauma. And at the Millennium, we've seen powerful results using nutraceuticals and hormone-based protocols. Patients within 5 to 20 years of post-trauma traumatic symptoms have shown marked improvement. A group of Vietnam veterans experienced significant recovery after decades of suffering. One remarkable case of a 94-year-old Korean War vet exposed to blast trauma suffered with dementia, which was confirmed by his neurologist as being reversed within 6 months of being on his protocol that we developed based on looking at his blood and giving him what the blood told us he was deficient in. The common denominator, reduction of the brain's oxidative load and neuroinflammation, and at the same time, improving the hormones of the brain. This brings us to something called peroxynitrite, which is one of the most destructive reactive nitrogen species, pro-inflammatory component produced in the body. It's formed from this ROS and another chemical called nitric oxide, which is a key vasodilator and signaling molecule in the brain. When nitric oxide is depleted to form peroxynitrate, we have loss of vascular regulation and therefore hypertension. Superoxide dismutase system is overloaded and you start building up more inflammatory chemicals. There's a breach in the brain's oxidative defense, creating an open border effect where just tons of free radicals surge in, creating an accelerated damage to the brain. This biochemical shift disrupts neurochemical balances and drives neurodegeneration. The impact of peroxynitrite on brain function can be dramatically visualized with Dr. Daniel Amen's SPECT imaging, which reveals metabolic and perfusion changes. A SPECT scan, single photon emission computer tomography, is where they inject you with a radioactive isotope. It piggybacks on the back of a red blood cell and then circulates in the body, and they look at the brain only. And when the circulation in the brain, the vasculature is perfect, it looks like this, with smooth, beautiful borders. Everything is great. But when you have these punched out areas, it's hyperperfusion, low perfusion of blood, because there's constriction of the blood vessels because of loss of nitric oxide. Now, these perfusion deficits are often due to trauma, oxidative stress, peroxynitrite formation, vasoconstriction from neuroinflammation, substance use like alcohol, amphetamines, cocaine, and vascular pathologies like microclots, hematomas, and tumors. These patterns highlight the real-time vascular effects of trauma and inflammation on the brain's functioning. We've established that peroxynitrate disrupts both brain perfusion and the neurochemistry of the brain. It also plays a direct role in depression, insomnia, and fatigue. Peroxynitrite inhibits two key enzymes, tryptophan hydroxylase and tryptophan decarboxylase. These two help to generate serotonin and melatonin. Without serotonin, depression. Without melatonin, insomnia, sleep deprivation syndrome. Now, what we've also found is that the inability of L-tryptophan to be converted to serotonin and melatonin backs up. And in backing up, you generate a lot of something called kynureninic acid. And what Dr. Takamura in Tokyo, Japan found is that this kynureninic acid is more related to depression than serotonin, which is made in the gut. 85 to 90% is made in the gut. So what he found is this kynureninic acid in the brain is associated with major depressive disorder. And in our veterans population, nearly 100% have symptoms of depression, insomnia, and fatigue because the inflammation and the presence of higher kynureninic acid creates the scenario. Another issue is that the brain accounts for about 2% of the overall weight of the body, but it consumes about 20% of the body's oxygen, reflecting the intensity of metabolism in the brain. The high energy output produces large quantities of these reactive oxygen species via mitochondrial respiration, raising the oxidative load, and it overwhelms the glutathione system and the superoxide dismutase system. To remain functional, glutathione must be continually regenerated by the enzyme glutathione reductase. It just so happens that peroxynitrite selectively inhibits this glutathione reductase, especially in the area of the brain called the substantia nigra, which, in all accounts, when that's damaged or not producing dopamine, causes Parkinson's disease. And what we found in our patient populations, there's a 61% increased rate of Parkinson's disease in footballers, American football, and there's a 56 to 83% increased rate of Parkinson's disease in veterans. One of the interesting statistics that I read was in a veteran who's never had head trauma, if you can find one, never had head trauma, at 65 years and above, their rate of developing Parkinson's disease is 1 to 3%. But with a history of one trauma, 56 to 83%. ALS, amyloid lateral sclerosis, 85% after a trauma. Traumas are really devastating. Okay. All right. So, fractalkine. Until now, we focus on how physical trauma activates microglia, unleashing pro-inflammatory cytokines that disrupt brain function. Physical trauma creating this scenario. But there's more. Discovered in 1997 by a company called Millennium Pharmaceuticals, which is not us, okay? Just coincidental, which was by fate. It turns out that fractalkine is a chemical produced by neurons and astrocytes. Its primary role is to suppress the microglia activation from arresting sedate M0 microglia into the pro-inflammatory producing M1 phenotype. What happens? Rising levels of cortisol, the stress hormone, whether from physical injury or psychological trauma, shuts down fractalkine production. This opens the floodgate for microglia activation, cytokine release, oxidative stress, and neurochemical disruption. In fact, non-physical trauma alone, such as chronic emotional or mental stress, can result in fractalkine depletion and trigger PTSD, mood disorders, and cognitive decline. Physical trauma or emotional stress both increase cortisol, reducing fractalkine, both ignite the same neuroinflammatory cascade. The pathways are shared, the damage is real, and the solution must target cortisol-driven inflammation. So I mentioned biological resiliency early on. So biological resiliency is how our lifestyle choices either fortify or weaken the brain's ability to resist and recover from trauma-induced dysfunction. Think of it as a neuronal Kevlar, bulletproof stuff, where a healthy lifestyle builds protective layers and an unhealthy one strips them away. Factors that build up resilience: quality sleep, nutrition-dense diet, movement and exercise, emotional regulation, and supplemented antioxidant support. Factors that erode resilience: alcohol, recreational drugs, polypharmacy or inappropriate medications, and gut dysbiosis, gut problems like ulcer, gastritis, gut inflammation, hyperacidity, and loss of the natural bacteria in the gut called dysbiosis, which can be due to stress, cortisol, COVID-19 vax, or getting COVID can wipe out the bacteria in the gut, which has been totally missed. And in our 30 years of clinical experience, the greatest barrier to recovery post-neurotrauma are alcohol, pharmaceuticals, and poor gut health. Optimizing biological resiliency isn't optional, it's foundational. Changing direction a little bit. Neurosteroids. What are neurosteroids? Neurosteroids are the hormones synthesized within the brain, within the cells, neurons, oligodendrocytes, glia, astrocytes, that directly modulate central nervous system function, imparting everything from cognition and mood to memory and neuroprotection. Neuroactive steroids, neurosteroids in the brain, neuroactive steroids, on the other hand, are synthesized outside the brain in the gonads, the testes, and the ovaries, and the adrenal gland. But some can cross into the brain through the blood-brain barrier and influence brain functioning. Together, these two classes of hormones regulate neuronal excitability, synaptic transmission, neuroinflammation, emotional regulation, and brain repair and resiliency. Low level of testosterone, as you see, will increase the brain's inflammation. Good, healthy levels, therapeutic levels of testosterone, estradiol, pregnenolone, allopregnanolone, progesterone will lower that. Additionally, all neurosteroids and neuroactive steroids are derived from cholesterol. So a low cholesterol level has been associated with depression, cognitive decline, dementia, and neuropsychiatric vulnerability. On the left side of this slide, there's a listing of some of the most important neurosteroids that we routinely measure in our 28-point biomarker panel, because when these decline, brain dysfunction follows. Restoring neurosteroid balance is one of the most powerful levers that we have to recover brain health. And we've seen it in over 12,318 people to date. As this study highlights, neurosteroids play a critical role in regulating the brain's response to stress, directly impacting the development of mood and anxiety disorders. In our clinical population, dysregulation of the neuroendocrine system is consistently associated with depression, anxiety, insomnia, agitation, and emotional volatility. These symptoms are not random, nor are they purely psychological. They are biochemical expressions of disrupted neurosteroid signaling. Yeah, and neuroinflammation. Correcting these imbalances is key to restoring emotional resiliency, giving people back their life. While commonly labeled as sex hormones, testosterone, estrogen, progesterone play powerful roles in brain health by neutralizing free radicals, protecting neurons, removing something called beta amyloid, which is the key protein found in Alzheimer's disease, and tau protein found in CTE, also multiple sclerosis, Parkinson's. It's found in all of them, to be perfectly honest. And it stimulates, these hormones stimulate neurogenesis, which is regeneration of neurons, and neuro repair, and helping with myelination and remyelination of neurons. If you lose myelin, you lose conductivity. These are not optional. They are essential regulators of cognitive resilience at every age in both males and females, in men and women. Maintaining optimal hormone levels is critical for mitigating subconcussive trauma, countering stress-induced neurodegeneration, preserving cognition, memory, and emotional regularity. The Max Planck Institute of Psychiatry, for any psychiatrists out there, has demonstrated that disruption of the neuroendocrine system is strongly associated with new onset, mood disorders, aggressive behavior, neuropsychiatric instability following trauma. Their recommendation go far beyond neuropsychiatric evaluations, suggesting that you conduct a comprehensive neuroendocrine assessment to identify neurosteroid and neuroactive steroid deficiencies. Their rationale is that their approach enhances diagnostic accuracy and enables precision targeted therapy. What medication that we have right now is precision targeted therapy. The term tilted axis refers to profound neuroinflammatory burden triggered by traumatic brain injury, which disrupts this neurochemical signaling that leads to persistent neuropsychiatric symptoms. The key point is the hypothalamic pituitary axis. Hypothalamus, pituitary, the master regulator of hormone balance, is frequently impaired after TBI, yet it remains absent from routine standards of post-TBI assessment and care. This oversight delays or prevents identification of the root cause, not masking symptoms, but finding out why those symptoms occur. So it looks at the root cause, resulting in treatments that merely suppress symptoms rather than restore function. The great fallacy of normal hormonal ranges. Reference ranges, let's see. Yeah. The fallacy of normal hormone ranges. In this example, I see the numbers are missing. In a hormone that has a range between 10 and 90, if you come in at 11, 99.9% of all doctors will say you're normal. But the person will say, "Doc, I don't feel well. Something's wrong." So the reference range provided by the laboratory are population-based, not patient-specific. My level of hormones might be higher than Jeff's or Jason's because I'm unique and my physiology, biochemistry requires what my body requires. It doesn't require what your body requires. I'm a unique entity. So these reference ranges are for the quote-unquote normal range, yet still may be biochemically and symptomatically deficient. Just as we adjust blood pressure or thyroid medication based on clinical need, not simply numerical values. So too much hormone therapy reflects individual functional baselines. The Millennium's clinical experience has shown the most consistent and robust patient improvements occur when the hormones are titrated to the third or fourth quartile, which means the 50th to 100th percentile of the range. And that's where we get the best recovery in our patients. Moving to testosterone, it's more than a reproductive hormone. It's something we call pleiotropic, which means it has lots of benefits. And it's one of the key issues is its immunological role in inducing something called interleukin-10, which is the main anti-inflammatory chemical produced in the brain. And what does it do? It suppresses all these damaging pro-inflammatory cytokines. So you need testosterone in the brain. We've already emphasized how chronic pro-inflammatory cytokines triggered by repetitive head injury drive long-term neuroinflammation. This article highlights a few critical insights. Neuroinflammation creates a hostile biochemical environment that interferes with therapeutic modalities. Why doesn't HBOT work in some people? Why doesn't this medication work in some people? Because their receptors and the chemistry of the brain is so poor that it destroys what you put in. And that's where resistance, treatment-resistant depression, treatment-resistant occurs. When inflammation is unchecked, it can distort neurotransmitters, receptors, alter synaptic signaling and plasticity, disrupt cell oxygen utilization, and decrease mitochondrial production of ATP. You don't have ATP, the lights are out. And these changes blunt the effectiveness of treatment, such as pharmacological intervention, neurofeedback, red light therapy, psychedelic-assisted therapy, and HBOT, hyperbaric oxygen. This 2017 study out of psychiatry in England, the UK, mapped the correlation between specific inflammatory cytokines and various neuropsychiatric conditions. The key findings showed that interleukin-6, IL-6, and TNF-alpha, tumor necrosis factor alpha, that they were the most consistently elevated across all forms of neuropsychiatric conditions. These inflammatory markers are not just diagnostic, they represent active biochemical targets for intervention by decreasing the inflammatory processes. Be aware that cytokines produced below the neck, from the gut dysfunction, from autoimmune diseases, from surgical trauma, from fractured bone, can cross the blood-brain barrier and go directly into the brain and turn on the inflammatory cycle in the brain. Your brain could be quiescent, no inflammation, but you break a bone, goes into the brain. Look at the studies. People who have fractures, why is their depression higher? People who have rheumatoid arthritis, why is their depression higher? Or psoriatic arthritis, or any of the autoimmune conditions? Because these inflammatory cytokines go right into the brain and mess with the brain's functioning. This is not psychological. It is a biochemical response driven by peripheral immune activation. Patients with long COVID often display classic sickness behavior phenotype due to persistent activation of microglia by the spike protein. Sustained elevation in pro-inflammatory cytokines, disruption of neuronal signaling pathways, mitochondrial dysfunction so you can't generate energy, and neurotransmitter dysregulation. Long COVID provides a real-time model of cytokine-induced neuropsychiatric dysfunction. We see in all our long COVID cases, we see a lot of psychiatric-related issues. The body and brain are in constant biochemical dialogue. Therefore, inflammation anywhere can mean inflammation everywhere. In patients who develop this sickness behavior syndrome following COVID-19 infections, concussion or subconcussion, brain trauma, post-stress or delayed recovery syndromes, the evaluation of gut health becomes essential, if not mandatory, in our offices. And that's because stressors like cortisol, SARS-CoV-2 spike protein, systemic cytokines alter the gut bacteria and kills it. Inflammatory bowel disease like Crohn's and ulcerative colitis are linked with increased risk for neuropsychiatric conditions. Gut dysbiosis is increasingly recognized in post-concussive syndromes. Why? Cortisol. Physical and biochemical injuries from traumatic neurotrauma Disrupt the autonomic nervous system, which is comprised of the sympathetic and the parasympathetic systems. Trauma induces inflammation, leads to overactivation of the sympathetic nervous system, resulting in increased epinephrine and norepinephrine, the catecholamines, increased heart rate variability, increased respiratory rate, increased blood pressure, increased sweating, increased temperature sensitivity, and decreased parasympathetic tone. These biochemical shifts drive the fight, flight, or freeze response commonly observed in anxiety, panic attacks, and PTSD, hypervigilance. Certain brain regions are especially sensitive to neuroinflammation, like the hypothalamus, which modulates the autonomic nervous system, hormonal output, thermal regulation, the amygdala, as we talked about, and processes emotional salient fear and aggression. Inflammation of these regions reinforce the autonomic hyperarousal, hypervigilance, causing a vicious feedback loop between trauma, mood, and physical symptoms. To break the cycle, we must reduce inflammation, rebalance hormones, and support the neurochemistry. Neuroinflammation may blunt the therapeutic effects of psychedelics in treatment-resistant depression and addiction. Look at all the stuff that's happening in the States and also outside the States, in Mexico a lot. All the benefits in addiction and depression. What I tell them, and have this paper published in 23, is that you need to fix the biochemistry before you throw the chemicals in so they work better. So hormonal evaluation is critically underused in traumatic brain injury care despite its strong link to psychiatric risk. In this study, 56% had one or more hormone deficiencies during this acute phase, identified as 3 months after the TBI, while at 12 months, 36% had deficiencies, so there was a 20% improvement. And this is in the chronic phase. This timeline suggests testing too early may miss evolving deficiencies. If you go in, someone has a head trauma today, you test them today, you're not going to find it. You need to wait 3 months. So what do you do during that 3 months? You put them on things to lower the inflammation. In 2016, I did a simple PubMed search looking for the relationship between hormones and depression. How many articles were published in Google Scholar? In testosterone and depression, 70,000, estrogen and depression, 99. So it lists there are a lot of relationships between hormonal deficiencies and the onset of new depression. And then I looked at it again in May of 2024. Yeah, May of 24. Look at the numbers, how much higher they are. People are now looking, researchers are now looking more intensely worldwide at the relationship. I almost lost it when I saw growth hormone in depression from 19,000 to 1.29 million articles. These are peer-reviewed, evidence-based articles. Okay, this slide highlights 24 of the 28 biomarkers we use to objectively evaluate patients with concussive and subconcussive trauma, as well as all the neurodegenerative conditions. These markers include hormones, neurosteroids, neuroactive steroids, markers of biological resilience, and those that are neuroprotective. Due to the complexity of this 28-point biomarker panel, we have an expert AI software application that's used to interpret these and to give predictive treatment suggestions. Okay? 12-page report walks the healthcare provider and the patient through all the changes that have occurred because of life, injuries, the accumulation of traumas. This chart highlights how select pleiotropic, many functioning hormones influence inflammatory cytokines, growth hormone, C-reactive protein, TNF-alpha, interleukin-6. All of these are benefited with the hormones. That's why we get such great responses, because we regenerate, give the patient back what they're missing. Where in the body is a Prozac gland? Where in the body is a Paxil gland? Where in the body is a Fexer gland? Where's a Abilify gland? I'll give $1,000 to anybody who can show me where that gland is. Any of them. And then we have targeted nutraceuticals. Took 16 years to develop this grouping through clinical trial and error, but using the research that has already been produced as directors in something called translational medicine, where the information already exists, but no one's using it because it's not a pharmaceutical drug. So this targeted nutraceutical combination reduces microglial activation by downregulating all the key neuroinflammatory pathways. And for an example, there are 3 studies similar to this. This one's done by the U.S. Navy Bureau of Medicine and Surgery. It was a controlled military study. Soldiers exposed to blast wave trauma overpressure received 4 grams of something called N-acetylcysteine, a natural product, over 7 days, and then the control group received nothing. In the placebo group that didn't receive anything, 89% of them reported insomnia, fatigue, irritability, depression. And in the NAC group, the ones who were given the treatment, only 14% developed symptoms. There was a 7-fold reduction in symptoms. Not a bad odds in 1 week. Protected them. And then once inflammation is under control, the focus shifts in the body. Once inflammation is controlled, the body shifts over to anti-inflammation and repair. That's when you need lots of energy to restore everything that's been lost. And this is a product or a combination of products that upregulate the brain's ability to produce ATP, to generate everything that's needed for repair. So, in closing, all forms of trauma, subconcussive, concussive, or psychological stress increase free radicals production and activate microglia and trigger cytokine release and disrupt the molecular and cellular functioning essential to healthy brain. Without proper evaluation, these silent biochemical changes may evolve into serious clinical symptoms. But once we recognize the subconcussive trauma alters neurochemistry, we gain a target for testing and a rationale for treatment. Knowing the key inflammatory drivers and how to neutralize them empowers us with prevention to mitigate and reverse brain dysfunction. For any athlete involved in contact sports, I strongly recommend establishing baseline levels of the following key neuroendocrine markers like luteinizing hormone, prolactin, pregnenolone, free testosterone, cortisol, insulin-like IGF-1, and DHEA. Routine follow-up should be conducted every 6 months. If the athlete experiences a concussion or subconcussive impact, repeat testing should be performed 3 months post-event to detect any delayed neuroendocrine disruption. Remember, if you do it too early, you miss it. And lastly, the gold standard would always be prevention through healthy lifestyle choices, neuroprotective nutraceuticals such as omega-3, vitamin E, B complex, and quercetin, following trauma, lab tests, and so forth. In February 2023, we presented a 3-year clinical review involving 840 participants. This was to AMSIS, Georgetown University in Washington, in Maryland, really. And this was a presentation of 840 participants, 388 veterans, and 452 civilians. 75% of the veterans had a VA diagnosis of PTSD. 25% were labeled with TBI. All of the cases were put on the exact same assessment and treatment. And they underwent the 28-point biomarker panel. All biomarker deficiencies encountered were supplemented to bring them back to the 50th to 75th percentile for their group. Their clinical outcome was monitored by something called an MPQ, Monthly Program Questionnaire. And these are the actual results of this group. In a year's time, 78.3% of the participants were 50 to 100% better within 12 months. And here are the actual numbers. 116 were 50% better, 89-60, 41 were 100% better, off all their medication, no longer symptomatic, Back in school, my partner was on 13 medications, full-blown alcoholic and suicidal. He's got an MBA, Masters of Business Association. He's now in law school. He was on 13 medications, couldn't do anything except drool from polypharmacy. At that point, I'm right on the nose, okay?
Doc, thank you so much for that. That was absolutely incredible. And I think everyone here is pretty blown away by you being able to share your time with us and showing us some of these things. And even to summarize from my own perspective, it seems like we're looking at inflammation as the disease, whereas inflammation is the natural process that we need to support ourselves in getting beyond that inflammation to get in that repair phase. So thank you so much for that time. And we've got a few really good questions that I'd like to kick off with too while we've still got you. So
okay.
David has asked, so hi Mark, thank you for the
Hi,
work.
David.
Former commando, lots of blast exposures. He's recently started, less than 2 months ago, a protocol with Dr. Elizabeth Harris in New Zealand.
Sure.
He's responding well and feeling stronger every week. And recently he traveled and picked up gastro. And again, I can attest to this too. When I get inflammation, a lot of things come back. So a lot of his progress was lost. And after 10 days, he's feeling strong again. He wants to know if he's correct in understanding that the systemic inflammation from illness overwhelmed the brain, which brought about the psychological symptoms again. And any specific tips and suggestions or advice next time for someone on the protocols or on the MTBI or SCTBI, if they get sick, what can they do to kind of override that?
Right. Well, unfortunately, a lot of our tools that we have here, you don't have there. So BPC 157 for gut-related problems is phenomenal. You do have vitamin D. Pushing vitamin D, we start off at 10,000 for our patients. Vitamin D is non-toxic. What is toxic is the calcium that is absorbed because of vitamin D. There are studies out there that show 300 nanograms per milliliter of vitamin D. Normally in the United States, it's 30 to 60. For us, it's 100, which finds that they had no symptoms at 300, at 200, 250. It's only when calcium was elevated. So we tell our patients, don't take any calcium supplements. Don't use Tums, which is an antacid that's all calcium. And try not to chew on any drywall.
Okay. Can I just support that comment, Mark? We can get access in Australia as a consumer to the BPC 157 capsules, which my understanding is more beneficial.
500 micrograms, 500 micrograms either at night or in the morning. Obviously, you stay away from some of the irritating chemistry that's out there, alcohol, heavy fats, and so forth while you're in the repair phase. Also, microbiota. If you've had the COVID, like most people in Australia have had the COVID, you're sitting on a time bomb. You can read the article that I dropped 4 or 5 months ago, the influence of COVID-19 on the microbiota. If you've had, doesn't matter whose, also if you've had the actual infection, your gut. So probiotics are important. And Dr. Harris flew into the San Diego in 2015, May, and was the first Kiwi to go through our program.
Brilliant.
So she flies out here. We were in Utah together in October. She got re-educated. So she's doing everything that needs to be. The only thing is getting our products to New Zealand and Australia. Amazing. They're all natural. The majority are natural.
And David's also got another part of that question, might be a little bit my understanding as well, but he's asking about the use of plasmogens or prodrome products, which seem to be helping, but they're not cheap. Do you have any knowledge on those?
Yeah, I've got one of the plasmogen. It deals with the immune system, but those are high cost stuff. Vitamin D is inexpensive, 10,000. If you go onto Google Scholar and start researching vitamin D and inflammation, there are, let's see, vitamin D and heart protection over 3 million. COVID reduction and protection, 1.43 million articles. There are millions of articles. Diabetes, 3 million. Cancer prevention, 3,080,000. Just unbelievable. What it does is stabilize the immune system and lowers the inflammation. Pregnenolone does that. Progesterone does that. Allopregnanolone does that. DHEA does that. Testosterone does it. Just by getting all your hormones to the 50th to 75th percentile will give you benefit.
Beautiful.
And then things like quercetin, green tea extract, zinc, very important for zinc. A lot of people don't do measurement of zinc. Zinc helps to regulate SOD in the brain, superoxide dismutase.
Okay. I've got another question here from Don. This is a really good one, but my pronunciation of some of the words is going to be crazy.
No problem.
You've indicated in slide 36 that individuals with physical issues such as arthritis have an increased likelihood to suffer from depression. And that is not just psychological, but due to the increase of inflammatory cytokines that then proliferate through the blood-brain wall. Please confirm that I reflect your comment correctly. If we are to utilize MSC or stomal cells through
mesenchymal stem cells.
Yep.
Yeah.
To treat the physical symptoms of arthritis, does that mean that we will have a correlation of assisting also to treat the associated depression with the systemic cells?
Well, let's put it this way. Understood. Don, anything you can do to lower the inflammatory oxidative load throughout the body will benefit the brain, whether it's coming from an arthritic knee joint, hip joint, back, fingers, wherever, shoulder. Dropping the inflammation will help. Mesenchymal cells will help if they've been passed through a red therapy before being given to you. Yes, because what happens is, depending upon where you get the mesenchymal cells in culture or if they're derived from other cells, can create inflammation. So if they've been exposed to something that was developed in Australia in 2013, it's a red light therapy for PCP or platelet-rich plasma, PRP, and for stem cells. I worked in Australia while I was in Thailand with a group in Sydney, I believe it was. So if it's treated so it doesn't give you the inflammatory cytokines that can be in things like PRP, that's why PRP is uncomfortable. But yes, the only problem is that you can go and read the article I dropped last week, which is the 2 I's of hypogonadism. Ibuprofen, any of the non-steroidal anti-inflammatories will shut down the brain's inflammation as well as shut down your ability to make hormones in the brain. It will also shut down your gonad's ability to respond to luteinizing hormone to generate testosterone.
Beautiful. I've got another question here from Paul.
Should I shut off the sharing?
Yeah, sure.
Yeah. Okay, I can do that. Okay, stop sharing. Okay.
So question from Paul, and again, this is exactly why we've hosted this today to speak to you, and also we're trying to promote some new awareness of these therapies. But he's asked, how do we access this therapy at the moment?
You know, that's the 100 million Australian dollar question. Wow. Okay. I mean, it's too far to fly where I am. And therefore, what we're doing, Paul, with Pro Patria and Jeffrey, is to build a network where we can bring in our treatment protocols. There are some docs, as well as Jeffrey, that are being trained in this science and technology. The software that I alluded to can help anyone in healthcare. We have nurses here. We have nurse practitioners, physician assistants. We've got naturopaths here who are doing all the same work that we're doing. They're drawing the blood, and they're processing the results in the software And the software, 12 pages, is telling them exactly what to do. So we have psych institutes that are using it in Austin, Texas, in Florida, in Hawaii. So we have a very good center. I don't own any of it. It's not my personality, but we have a very good center in Hawaii with Dr.
It's
Jason
also why we've got
Kiefer.
Jeff here today too, because again,
Yes.
Jeff, our Aussie contact in this as well. So the
And
work
that's
that Jeff's doing in the background too is going to help
Yeah,
us.
this is what we're trying to do. As Jason just said, we're trying to build everything homegrown in Australia.
Awesome.
Yeah, Paul, I can just interject there that all the structures are in place. It has taken a sufficient period of time because we have lots of different regulation processes in Australia, lots of different hoops that we have to jump through, much more stringent than what the US is. So all the foundations and structures are in place. So we're just at the moment looking out and currently onboarding practitioners, which we have a couple of training. So my advice is, I think we've got Paul's email and anybody else's email who is interested in Mark's protocol. We'll add you to a database and we'll keep in contact with you frequently and update you as soon as we go live.
Beautiful. We got another question too, which is any particular insights into TBI treatment from ibogaine, peptides, and/or stem cells, and as they would recommend it to see, or is there anything out of them that you'd recommend to see real promise in?
Well, I work with seven entities. They're 501(c)(3)s, charitable organizations owned and operated by veterans. One of them's with Richard Branson on BVI. And ibogaine, ayahuasca, psilocybin, MDMA, they're wonderful drugs in the right hand. But before you even do that, fix the chemistry of the brain. Very few of our patients go on to do that. Some of them come to me, Doc, I'm feeling great, but I'd really like to experience this ibogaine or ayahuasca. I said, go do it. Go do it. And they come back, they said, yeah, I feel a lot better. I've got a guy who runs 5 ibogaine centers outside the country, ex-F-18 fighter pilot, who has had multiple ibogaine sessions. And he came to us 3 months ago and he said, I did really well with it, but I'm not there. And when we ran his labs, the reason why he wasn't there is because he had 3 or 4 of his important hormones in the brain were deficient. Within 24 hours, I kid you not, 24 hours, he calls me and he says, Doc, I'm feeling great. I'm running 3 miles in the morning. I'm blah, 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 blah. Okay. So it's done very well. He's done very well. And some of this stuff, the last Joe Rogan, the 6th Joe Rogan I did, 2262, I talk about stroke. I talk about ivermectin and cancer, brain-related stuff. What else is there? An organization called Biohack Yourself, which will be moving to Australia, New Zealand, and so forth in time. But to answer your question, first thing you need to do is get the biochemistry fixed. It's, I'll eventually come up with an analogy about a swimming pool and what you put in the water, will you swim in it or not, So all those things that you checked off, they're really good if you need it. But very, very few of our patients need HBOT, hyperbaric oxygen, need psychedelic assisted therapy, PAT, need, ketamine, which I don't like. Okay. It's a stopgap.
Mark, can I just interject there and just refer back to your movie, the documentary, and if anybody
Not
hasn't
my movie.
Oh, sorry. Well, apologies. I'd recommend watching it, Quiet Explosions. But in that documentary, I think it was the surfer. I can't remember his name. He was doing
Sean Dollar.
Yeah, he was getting benefit, but his brain wasn't. It was the volume was still the same, wasn't it? It still was reduced.
Yep.
Until you corrected the neuroinflammation. So is that right?
He had 81 sessions of HBOT. While he was doing it, he did phenomenally well. Symptomatically, phenomenally well. 2 weeks after stopping it, he crashed and burned. Wow. Then they sent him to me. We checked him out. We found his hormone deficiencies. corrected it. 2 weeks after correcting it, he's doing better. I told him, stay calm. He ends up going back surfing. He felt so good. He stressed himself out. He had hypocortisolemia. He had Addison's-like condition. So low cortisol. And he just stressed his body and lost it.
Yeah, and we're constantly hearing that it has to be a multimodal approach where you're holistically treating, not just one solution. And so it's so important that we look at all these things. I've got another really good question here, which is again above my even understanding, but what information do we have that strengthens the pentad super syndrome cluster correlations? What are the latest updates regarding treating mitochondrial-driven neuroinflammatory symptoms such as migraine, dystonia, and stroke-like episodes?
Okay. We had the mitochondrial dysfunction can be from maternal DNA related, but the majority of cases we see are due to neuroinflammation and mitochondrial dysfunction. When you have inflammation, what happens is the mitochondrial, they call them windows, open up and they release a chemical that destroys the cell. So autophagy is something that you've heard about for longevity, where you starve yourself to help reset your mitochondria and your cell functioning. We use PQQ and CoQ10, and we have a product which is called B is for brain, which upregulates mitochondrial functioning. PQQ might not be a common CoQ10 that you know about, but it's 100 to 1,000 times stronger than CoQ10. It also has a quality similar to quercetin, which is a natural product, comes from apples and so forth, which it can upregulate mitochondria production in the cell. So within a week, you can double your mitochondria. So if you have mitochondrial deficiency, you can't produce ATP. Anyone who takes a statin drug can have that aches and pains of the muscle because it damages mitochondria. So using PQQ, quercetin, magnesium, what else is on the list? B1, B2, B12, methylated, will help mitochondrial dysfunction and correct the mitochondria. But as long as you have inflammation, it's going to take a little bit of time. And remember that the mitochondria in their normal oxidative phosphorylation, which is where they make ATP, will spin off an oxygen radical that's damaging. So you need to have good antioxidants. They could be fish oil, they can be vitamin C, they could be curcumin, they could be just a whole litany of antioxidants in your system. Okay, I use a lot of quercetin. What else is on the list? Quercetin, vitamin E, gamma tocopherol, which is gamma vitamin E, and N-acetylcysteine and glutathione in one of our products, which is called Brain Care 2, which went through testing with the medics out of Fort Campbell, Kentucky. So every one of our products have gone through testing with military SEALs in the beach in Virginia. With our first product, second product was with the medics, and then our last product, our key product, Brain Rescue 3, with the Marines out of Camp Pendleton, First Recon Group. So I wrote the paper, it finally released. It was a 4-year trial and error to get it out. But 65% of them were 50 to 100% better in 90 days.
Wow. We've probably got time for a couple more questions, and one of them actually ties into one of the things you just mentioned as well. Someone's asked about water fasting, and again, I've even witnessed this with other people that have reversed cancer by going on this, and it kind of links in, I think, to ketosis. So what's your kind of take on?
I have absolutely nothing to do with water fasting. Okay. My focus is neuroendocrinology, neurophysiology, dealing with neurosteroids, neuroinflammation, neuroimmune, neuropsych.
Yeah.
And people think I'm psychologist, psychiatrist. I keep on saying, no, it's a side effect of what we do, you know? It's like you put air into a tire and it fills up and the person can drive. Am I a tire expert? No. I just know how to put air into a tire.
Yeah, cool. So out of that, then, how do you see ketosis working in for that when people are in ketosis?
I don't like it in traumatic brain injury because there are articles out there that state that obviously the brain runs on carbohydrates, ATP, carbohydrates. So when you put yourself into ketosis, you're starving yourself and you start challenging the mitochondria and they start kicking out more reactive oxygen species. So, I've had this argument for 3-4 years now when ketosis was, a big thing. I don't like it. You need to feed the brain. After they're better, you want to put them on ketosis, do it. I personally am hypoglycemic. Yeah. So if you want to see me yelling and screaming and shaking and tremors and volatile, get me in ketosis.
Can I just add on to that?
You don't have to ask, Jeff.
Yeah. So just in the science of that, right? Like my background, obviously health and rehab science, and big in the fitness kind of having a strong fitness background. So we know that the conversion in terms of the glycolysis and generating ATP, you generate around 32 to 34 ATP molecules rapidly. We under glycolysis, sorry. So with taking glucose, ketosis, obviously we're more reliant on fats. However, the production is very slow. And going back to what Mark said earlier,
96 molecules of ATP,
2% of the brain volume, but 20% of the energy requirements. We need something really, really efficient. Back on the hydration too, or the dehydration. When we have dehydration of a cell, we lose that cell volumization. So you can also get the lysis of a cell happening and occurring under severe dehydration as well. And we know that glucose attracts water. So wherever a glucose goes, water goes as well. So we lose our hydration when we actually go into ketosis as well. In saying that though, yeah, look, I mean, I guess off of that, understanding that then, Mark, right? So we're reducing the amount of energy required to the brain, but we're also reducing the water volume as well. So if we think back to water fasting, can you make any comment to that? How that would impact the brain, or you can't now considering those factors? Yeah.
Nope, not what I do.
But if we were to think about the fasting and the promotion or the benefit of removing, apoptosis, so, cleaning up and mopping up, poor performing cells, and the replenishment of mitochondria as well, or the repair of it, would that not be helpful? So I guess it's a double-edged sword there in considering ketosis.
Yes. As I said, at the beginning, I wouldn't even touch it. Later on,
yeah.
If there's a need to do it. And what you can do is side by side, okay, stop eating for a week. Let's see how you do. Eat everything you want. Some good Australian, steaks, Wagyu. That's what I eat. Okay.
And even from my own experience, I mean, I've dabbled in ketosis. In fact, that's one of the things that helped me first kick off my journey of healing, because it changed my diet and fasting. So I've had good experience in that too. So I would love to delve more into that in the future as well. I've got another great question here by Alistair, and he says, thank you, Dr. Mark Gordon. Now, Alistair has been diagnosed with CFS, fibromyalgia, PTSD, neurobiolosis, which is the Australian acquired tick-borne infection, brain injury, electro hypersensitivity. He's been monitored by Emeritus Professor Dr. Martin L. Paul and Donald Lewis, Dr. Sarah Mayhill, Professor Kenny Demir. So a lot of key names in that. Do you know Professor Kenny Demir and Dr. Dimitri Neitard's research on
neuroborreliosis? Yeah, tick-borne. Yeah, tick-borne. We have We have some people with tick-borne illnesses. As long as they've been treated to kill the bug, what happens is it leaves a residue in the brain that creates neuroinflammation. So what we see are people with, I've got one right now, with borreliosis, Lyme's disease, and they're getting better. They've already been through their medical, but it's inflammation. Things like CMV, cytomegalovirus, things like Epstein-Barr virus. We have patients who have had seizure, excuse me, not seizure, have had, what is it?
Epileptic fit.
They have epilepsy, migraines. I've a guy, Marine, he was having 3 migraines a day, 3 to 4 days a week, 6 months into his treatment, no longer having migraines. He ends up getting a girlfriend, getting a job, getting out of his cave of an apartment because he couldn't do anything. He's working. Then he starts going to the gym, and in the gym, he develops post-workout migraines, which is due to change in the biochemistry of the brain, inflammation. And the treatment for that is either a beta blocker or Viagra. Turned out Viagra helped him. Low dose, 10, 15 milligrams, low dose helped. But in the, these are all neuroinflammatory processes. There's 2 doctors in Granada, Spain, who have developed a PET scan where they can actually look at microglia, the glial cells, when they're turned on. So if they're turned on, that means inflammation. And therefore, they can treat it and see what products shut them off. So if you were able to look at the inflammatory parameters, you would probably see they're very high. I just started working with a company. We'll be testing out our first group of veterans for a genetic, let's see, it's not genetic markers, but they're genetic related markers for inflammatory chemistry. So we're doing, before treatment, we're looking at 50 markers, genetic markers of inflammation, and then put them on treatment and then go back and run it again and see if it's reduced it and see if it correlates with their improvement. Improvement not only in their hormonal level, but in their emotional state, their improvement in emotional state. So there's a lot going on, but these are all inflammatory based. One of the things with, I think I saw fibromyalgia, mitochondrial condition, you might look at PQQ and L-ribose or D-ribose. You can look up D-ribose and fibromyalgia. Study was done, double-blind crossover study, showing the reduction in fibromyalgic symptomatology when D-ribose was added to the mix. Why D-ribose? It's the backbone of ATP, ADP, all of the energy molecules. Ribose is the backbone, and you got adenosine, and then you've got triphosphate, up to 3 phosphates, inorganic phosphate.
Amazing. I think we're kind of getting toward the end now. So,
okay,
Dr. Mark, thank you so much for your time. Jeff, do you have anything else you want to jump onto the end there?
No, just on the end of that topic that Mark was just on. So with the fibromyalgia, I can never pronounce that properly. Right. There's often benefit associated. Is that what you're correlating it to with supplementing with vitamin B, having vitamin B deficiency, or can you talk to that for a moment?
Yeah, if you know it,
B12.
If you look at all the components that help the cell to transport inorganic phosphate, generate adenosine into the cell so it can go transported by CoQ10 and PQQ into the inner membrane of the mitochondria to go down the phosphorylation process, that B vitamins are important. You can do a scan, PubMed or a Google Scholar or you can go to, if you're using ChatGPT or Grok or one of those, you can tell it, you're the expert in mitochondrial functioning, go to blah, 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 and give me a 3-page report on the importance of every vitamin in mitochondrial functioning. And you'll see, incredible chart. So yes, B vitamins are given. That's why red meat is so important to the diet. It's got all the B vitamins in it.
And what's crazy about all this, it seems so glaringly obvious that we're, but yeah.
Then why isn't it obvious?
I know, it's crazy. But yeah, no,
I agree with you, Jason.
I think that's a great way to wrap it up. So, gentlemen, thank you so much for your time. This has been truly, I feel like a pivotal moment and a paradigm shift in the way that we're looking at these things. So to have you guys included, that is incredible. We're going to put together a package too. Dr. Gordon's been nice enough to share this presentation too. So we'll make sure that you guys can get a copy of this. We'll also have this online so people can view this, and we're hoping to expand from this as well. So this should be the first step for us to start branching out. You mentioned too, Jeff, Quiet Explosions. Again, a fantastic documentary. We're going to start looking at getting more access to those documentaries too, so we can really share what's happening in this wider scope. So, gentlemen, thank you so much for your time. It's been an absolute pleasure, and we hope we can do this again at some point in the future too.
All right. Thank you all. Appreciate it.
Yeah, bro.
Thank you.
Thank you.